Hello, everyone. My name is Ufoma Oyibororo, and here at the School-Based Health Alliance, we would like to thank everyone for attending today's webinar titled Beyond the Pill, Part 2, Sharing the Science, Tools for Describing Data Using a Patient-Centered Framework. Today's webinar is the second of a three-part webinar series. During today's presentation, we will explore key principles of patient-centered counseling and discuss how to offer non-judgmental contraceptive counseling in challenging real-world situations. Before we begin, if you are viewing as a group, please open the chat window by clicking on the chat icon and type in the name of the person registered for this webinar and the total number of additional people in the room. This will help us with our final attendance count. The School-Based Health Alliance is the national school-based healthcare advocacy, technical assistance, and training organization based in Washington, D.C. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. As youth-friendly and accessible settings, school-based health centers are uniquely positioned to deliver high-quality, confidential services that equip children and adolescents with the information, tools, and support they need to be healthy and safe where they are when they need it in school. We believe that all children and adolescents deserve to thrive. When health and education come together, great things happen. Now, we have a few housekeeping reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during this webinar, please use the chat tool located in your Zoom control bar. We will address questions following the presentation. Also, at the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 1 to 3 business days. Please also visit the School-Based Health Alliance website for additional archived webinars for topics such as the ones you are viewing on your screen. Now, I would like to introduce our presenter for today. We will be hearing from Lisa Stern, a nurse practitioner and a clinical trainer with the Bixby Center for Global Reproductive Health of the Department of Obstetrics, Gynecology, Reproductive Sciences at the University of California, San Francisco. Lisa?
Thank you so much. Thank you for having me. I'm going to go ahead and share my slides now. It's a thrill to be able to present this presentation to you all, in particular because I work now, my clinical practice is in a college health setting. And so similarly, I sit at that juncture of education and healthcare, and many of the patients I see attended school-based health centers in their teens. And so I see some of your alums. So thank you for having me. And please do feel free to put questions in the chat. I'm really excited to be presenting, but hopefully to be having a dialogue about this information today. So the title of today's presentation is Sharing the Science, Tools for Describing Data Using a Patient-Centered Approach. And we chose the words sharing the science really deliberately as opposed to presenting the science, because our belief is really that science, you know, even the published science is really part of an interaction between patients, providers, researchers, policymakers, the public, and that we're all kind of part of the mix of shaping what that science is and how it gets interpreted. And so what we really strive to do is to invite patients in and really invite them into that conversation to look at science and data together. And that's what we're going to try and cover today. And our belief is that patients are experts in their bodies and in their lives. And also, we often have access to and familiarity with scientific data, which is, of course, part of why patients come to us. But part of what can be challenging, and I think that probably all of us who see patients deal with this, sometimes what a patient is coming in with in terms of their experience, their pre-existing belief, information that that they've seen that may or may not be consistent with what we know to be true. Sometimes those things don't line up with what we've been taught or what the scientific literature shows. And so we can get in those uncomfortable kind of standoffy spots. And so we have identified a couple of more challenging areas that sometimes come up in contraceptive care today to figure out kind of how to work through those sticky spots and stay on the same page with our patients. I'm part of the Beyond the Pill program. I hope many of you were able to attend the first webinar in the series, and definitely encourage you to attend the next one as well, or listen to recordings if you're not able to go live. This presentation is kind of a middle ground between the two. I know that those of you who were able to attend the first webinar already saw a lot of great data. Today, we're going to talk a little bit about how to present that data, talk about that data in a patient-centered, patient-friendly way. And then the third in the series will go really deep into patient counseling and teach you some really practical techniques. I have no financial relationships to disclose. Our planning committee, for the most part, doesn't have any financial relationships to disclose except for Dr. Darney's and Dr. Shah's disclosures, which you see here. And I also really want to thank our expert reviewers who you see their titles and affiliations detailed here. This group of people lend invaluable feedback to the entire curriculum, but certainly to the material that you'll see today. And also want to thank our funders. So as a bit of background, the Beyond the Pill program began as a research study and has blossomed into a training program, and in its various incarnations has improved access to the full range of contraceptive options, in particularly IUDs and implants, which we know can be a little bit more challenging to stock and provide, for more than 2.1 million women each year. And through that program have trained over 6,500 providers, all over the United States, including Hawaii and Puerto Rico, and not depicted here, also the Northern Mariana Islands. And if this is something, if you're interested in learning more about this program and potentially having an in-person training in your setting, please feel free to hop on our website, get in touch with us. It's, we are thrilled to be able to bring this to more settings. These are our objectives for today. We're going to talk about how to apply principles of shared decision-making in the context of contraceptive counseling, describe techniques to present scientific data with clarity using a patient-centered approach, and we're going to go through some common challenging scenarios in contraceptive counseling. And if there are other challenging scenarios that you encounter, I really do encourage you to please throw them in the chat, throw them in the Q&A. We would be very happy to discuss those. So, some definitions. What is contraceptive counseling? So, contraceptive counseling is an interactive process which is designed to educate patients about contraceptive options, to discuss current and future contraceptive needs, and select a contraceptive method if desired. And I want to flag that if desired, because I think one of the underlying principles that we hope to convey today and certainly in the next webinar is that one of the things that can really help, I think, in taking a patient-centered approach is detaching ourselves from the outcome of a counseling session or the outcome of a patient visit. And I know that, often when we have so little time with our patients and we care so much about their well-being, it can be very tempting to feel like, God, I just want this person to leave with a method, or I just want this person to leave, even say knowing about all the methods. And one of the things that I want to kind of focus us on today is finding out what the patient wants to get out of that time together and focusing on that. And that part of what we're really doing, or most of what we're really doing, frankly, is building a relationship, establishing trust, and that based on that relationship and that trust, it will allow for, whether it's in that 15 minutes or another time, more free flow of information and good decision making on both parts down the line. So what is patient-centered care? It's defined by the National Academy of Medicine as care that is respectful of and responsive to individual patient preferences, needs, and values. So the nexus of these things, of contraceptive counseling and patient-centered care, is patient-centered contraceptive counseling. You know, as a presenter, it's like always a huge joy and a relief when animations work. So I feel we're already off to a great start today. Shared decision making, also just to define a term that often comes up in this context, is a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account what's described as the best scientific evidence available, as well as the patient's values and preferences. So depicted a little bit of a different way, you'll see that there's these kind of shaded circles, the patient's and family's goals and preferences, clinical expertise and evidence. So, right, that's like us, that's what we're bringing. And biological, psychological, and sociological context. So, you know, that's a lot of vocab, but basically what does that mean? Biological. So that's, you know, things like medical comorbidities, right? Other things that might be happening, other concomitant medications, so other relevant biological or medical facts. The psychological context, right, is the patient coming in with a lot of other things on their mind. Maybe this isn't the, you know, best opportunity for a particular decision that day. Or maybe they're really worried about this particular concern. Maybe they're really worried, for instance, about getting pregnant. And part of what we're doing in this shared decision making is helping to provide that psychological support, quell that worry a little bit, and meet the person where they're at. And then the sociological context. So this is a huge one often, right? So this is factors, you know, structural and social determinants of health. What else is happening in their life? What else is happening in the community? You know, hopefully a little bit less relevant in a school-based health setting, but often things like transportation. Can the person get to the clinic? And then, of course, the sociological context of a lot of the history of healthcare that can come to bear in patient interactions. What I like about this particular depiction, and it's credited here, it's from Cincinnati Children's Hospital, is that it's all shaded and overlapping. And I think one of the things about shared decision-making is that, you know, it's not a linear process, and sometimes it can feel like multiple things are going on at the same time. It can feel sometimes like there's a little messiness to it sometimes. And I think that's something that often with our kind of scientific background and training in healthcare, we resist, but I think shared decision-making helps us have a more comfortable way of leaning into that and recognizing that which clinical evidence and expertise we share will depend on a person's goals and preferences. It will depend on that context, and that's appropriate, and that's what enables us to be in that kind of that shaded area in the middle, that sweet spot that the SDM is pointing to, where truly shared decision-making really happens. So we're going to focus in a little bit more on this kind of clinical evidence and expertise piece today, so that we can also all feel like we have important facts to bring to bear at the table. So why do we do this? Why do we do patient-centered contraceptive counseling? Like, what's the deal? So some of the things that we know from studies that patient-centered counseling can improve include contraceptive knowledge. So when we take a patient-centered approach, when we kind of start from where the patient wants to be, it actually helps them leave knowing more than they otherwise would. The patient experience of contraceptive counseling, so people prefer to be counseled in a patient-centered way. It improves contraceptive use and continuation. And so as much as, you know, we talked about not wanting to get too attached to outcomes, this is a really important one, and I think one that can be surprising, right? Like, we know that patient-centered, or it makes sense, right, that patient-centered contraceptive counseling, that people would like being talked to that way, of course, or talked with that way. But this is an important one, that when we take this approach where we're focusing on what is the person coming in for, what do they care about, as opposed to thinking about what method do we want them to leave with, or what specific information do we want to convey, that it can actually improve their selection and use of their contraceptive. So on the contrast, provider-driven counseling, so when we come in saying like, I'm going to go through everything by tiers, I want to go through every method, I want this person to choose the most effective method they can. So any kind of like provider-driven approach, in contrast, can be associated with lower satisfaction and method discontinuation, which is not to say that you might not explore every single method. If the patient wants to know every single method available, then that's what you're going to do. There's no specific approach that is, more patient-centered or more provider-driven, but the emphasis here is really kind of letting the patient take the lead. And part of why this works so well is that, as we all know, this is really intimate decision-making, right? Like in talking about contraceptive counseling, people are talking about their future hopes and dreams. They're talking about their sexual activity. They're talking about their partner, their relationship. So this approach is kind of concordant with the intimacy and complexity of what's happening for people. So let's go through a couple of cases and kind of think more. This is a lot of theoretical information, and let's bring it kind of a little bit more into the clinic. So here's our first case. This is a person named Joselle, age 16. Joselle's pronouns are she, her, and hers. Joselle had a Nexplanon implant inserted last month. She comes in saying that she's bleeding every single day. She's calling to schedule a removal. So when we do this in a room, I always ask for a show of hands of like who's had a patient like this. And I would say usually every hand goes up. This is a really common scenario. And we're going to go through some data that can kind of help us to have a conversation with Joselle in a way that's really grounded in the evidence. And one thing that I want to just note right here in this case is that we say she's calling to schedule a removal. So one of the things that I think is really important in thinking about this patient-centered approach is that, it's like soup to nuts of everyone who works in a clinic. And so, I know that often, sometimes in school-based settings, a nurse or, a nurse practitioner or physician is working pretty independently. But if you are in a bigger setting that, even the people answering the phone and, all of us who provide any aspect of care, we're all part of this responsibility and privilege of talking to people in a patient-centered way. So I have a little poll question for you, which is how you would start this conversation. So if you had to choose just one, these may be things that you want to do. You might want to do all of these, but would you A, encourage Joselle to stick it out a little longer? B, assure her that irregular bleeding is common and usually not a cause for alarm? Offer her some options that can help reduce her implant-related bleeding? Reassure Joselle that she can have her implant removed today or be referred if you don't do a removal in your setting, or express empathy for her about the bleeding. So we're going to launch a poll. Great, and choose just, your top option. Hopefully the poll launched for everyone. I'll take the poll too. We'll leave this up for about 30 seconds. Great, I'm seeing the results pull in. I'm not sure if you all are seeing these too, and I'll share them out in case you're not. So express empathy for Joselle about the bleeding is the top choice at 42%. Reassure Joselle that she can have her implant removed today or be referred for removal, 21%. Actually, there's a kind of cluster. So B, C, and D all have about a quarter, 20 to 25% of folks. And encourage Joselle to stick it out a little longer. was the laggard at 4%. So I'm so pleased. So it seems like a lot of you are already already have really patient-centered practice. And I think that B, C, and D are all things that you would definitely want to do in this visit potentially. Encourage Joselle to stick it out a little longer. If she's really committed to the method, then encouragement might be appropriate. It probably isn't what we would lead with, but expressing empathy, which was the winner in the poll, I think that's also how I would start. And something that we're going to talk about a little more is that in terms of that patient-centered counseling, being able to establish rapport in the beginning of an interaction can be really helpful in helping people to really feel like you care and can help them kind of convey their needs. Okay, so goals of this discussion. I'm just going to walk through these briefly. Want to show care and concern. So as many of you already noted, you're going to express empathy. Assure Joselle her wishes will be respected. Hugely important. We're going to go more deep into this. Provide reassurance and anticipatory guidance. Elicit Joselle's preferences. That's probably the most important one. And offer Joselle the range of available options. So if you have to do only one, I would elicit those preferences. And ultimately, while as clinicians, we ultimately determine what options will be medically appropriate for her, part of shared decision-making is presenting those options in a way that can help Joselle kind of take them in and understand what her options might be. So this case seems simple on the surface, but it's actually juicy, I think. So we're going to kind of take our time unpacking it. Oh, and also I missed one, but assess Joselle for any non-implant related causes of bleeding. So here's one way to think about the goals of contraceptive counseling, and you'll note that these are overlapping. So some of our goals are to, empathize and reassure. We already talked about this. Offer information and a range of options. Normalize, so help the person feel like what they're going through is it's not freaky, it's a normal experience, and make a plan that works for the patient. So that's the most important thing, right? It's like a plan that's going to actually work for that person in the context of their own life. So focusing in on the kind of offer information piece. So this calls upon our kind of clinical expertise piece and offering information. So what are some pieces of information if you want? You can use the chat function if you have it up, but what are some pieces of information that you would want to offer Joselle? Feel free to chat some things into the bar here of things that you'd want to offer, information that you want Joselle to know. You can put it to all panelists and attendees so we can see everything. Great. The bleeding with the implant is totally normal. Yep, that's actually my top one in my list too. Many users experience irregular bleeding. Yep. What else might you want Joselle to know? Great. If she wants to keep the method, how does she plan for irregular bleeding now? So right. So what's she doing now? Is there anything that's helping? Is there anything that's making things worse? And if she wants to keep it, what kind of plan would she make? What kind of plan would she be open for? Wonderful. Oh, nice. And another one that just came in, I think just to me, that there might be other things going on. Right. So you're going to want to assess for those other potential causes of bleeding. And so that's something that you're going to want to share with her. Nice. So, and there are other therapies to help stop bleeding prior to removing the device. Right. So if she does want to keep the device, there's other options for her. Beautiful. So another poll question for you. What percentage of Nexplanon users experience irregular bleeding? I think a poll question is going to launch for us. Here it is. So what percentage of Nexplanon users experience irregular bleeding? Give a little time for those answers to roll in. Take your best guess. All right, and in the chat, we have a 1 out of 10. All right, are you ready to display those answers? Great. So we have a tie. Wow, you guys, this is so exciting. 50% and 80% are tied at 39% of respondents. Another 17% of respondents are say 20%, and 4% say 100%. So across multiple clinical studies, the answer is 80%. And of course, you know, it varies from population to population. But it's what this information can be helpful with is that normalizing piece that we just talked about. So it is really normal. And let's focus in, let's go a little bit deeper into this information. So in an analysis of 11 clinical trials, about 80% of implant users experienced irregular bleeding, especially in those first 90 days after initiation. And this pie chart breaks down between all of the people who had irregular bleeding. For about 60%, it was infrequent irregular bleeding. For about 20%, it was amenorrhea, no bleeding at all. 20% had frequent irregular bleeding. So that's why they have the red slice of the pie. One thing to note, though, is that the type of bleeding and the amount of bleeding isn't necessarily predictive of how bothersome it is for people. So I'm sure you all know this from working with patients. Some people are tremendously bothered by amenorrhea, and for other people, it's like a really wonderful side effect. So it's really very personal. Bleeding, however, can often be related to discontinuation. So it's a pretty common reason for people who discontinue the implant before its expiration date. So among people who do discontinue the implant before its expiration, 46% list bleeding changes as their main reason. And in a study of people who had an implant removed within the first 6 months after it was placed, 53% cited bleeding changes as a primary reason. So, you know, as people had said in the chat before, you know, this is the first thing they want people to know is it's really normal. And you can tell Joselle, both from your own experience and from data, that this is one of the most common issues that people encounter on the implant. So one thing that I do want to note is around a concept called numeracy, which is basically the number equivalent of literacy. So 80%, you know, makes sense to, you know, to many of us with advanced education or who feel comfortable with numbers. But it's important not to assume that patients have that same facility or that same way of talking about things. So this slide just offers a couple of different visual options for representing 80%, which can sometimes be helpful for people, or even saying, instead of a percentage, saying 8 out of every 10, or in this case, 4 out of every 5. So you can say if 5 people were in this room who had the implant, 4 of those people would be having irregular bleeding. That's how common it is. So another poll question, I'm really enjoying this, for what percentage of patients like Joselle, who are having this kind of everyday bleeding that's annoying to them, for what percentage of patients like Joselle do bleeding patterns improve? I think another little poll is about to come up, and you can also chat if the poll isn't working for you. So is it 20%, 50%, 80%, or like about 100%? So if you say, Joselle, just give it time, for what percentage of people does it get better? It'll take just a few more seconds to get those answers in. All right, what do we have? Okay, God, this is so interesting. People are doing so well. So many people guessed 80%, 48% of people guessed 80%, which makes sense. That was the right answer the last time. 39% of people guessed 50%. Another 9% guessed about 100%. You're like the best people, the optimistic people. You're the people I want to have lunch with. And then 4% of people guessed 20%. So the answer is 50% in studies. So among women who initially reported unfavorable bleeding patterns, about 50% noted improvement over time. So Before we give Giselle a bunch of information, how do we assess whether she's interested in learning more about her options? So this is a really important piece. 'Cause I know that we all talked about these things that we want Giselle to know. And sometimes it's kind of tempting to dive right in, but let's make sure that she wants to know. So this is just a sample way to kind of empathize and offer options. So it sounds like this bleeding has been very bothersome for you. So that's why we're expressing that empathy. We can remove your implant today, and I'm happy to do that. So we're offering reassurance. We can also talk about some options that would allow you to keep your implant, but could make the bleeding better. So we're offering options. And then eliciting her preferences. Would you be interested in learning more about those options? So this is really critical. Joselle was calling to schedule a removal, but we may think like perhaps she likes it and maybe she wants to know that there are ways to make that bleeding better. But before we dive in with that information, it's just important to assess and make sure that she wants to know. And I think a similar script, I think, can be really helpful when you see people who are coming in with a specific contraceptive method on their mind. So I had a patient this week. I was in clinic on Monday and she came in and she, for contraceptive counseling. And I said, like, oh, do you have a sense of what you're, looking for in a method? What are you thinking about? And she said, I want to get Depo. And so I think there can be two ways that sometimes we go in that situation, right? One is like, okay, well, let me tell you about everything else as well so that I know you're making a good decision. And the other is like, great, let me go get the Depo. And I think what I'm suggesting here is a third way, which is to say like, oh, terrific. I'm like, we have Depo here. That's an option for you today. There's also a whole range of other options, some of which you may or may not know about. Are you interested in hearing more about those too? So leaving it up to them. So let's say in this case, Joselle, she would like to keep her implant. And so she asks you about some options to manage her bleeding. So why is it important that we make sure that we reassure her up front that she can have her implant removed that day? So the reason is because there's emerging evidence that patients encounter multi-level barriers to desired LARC removals. So this data is from a recent study of almost 800 previous LARC users. And in that sample, about a quarter of people, 27%, reported that their LARC was removed later than they wanted. And that later, that could have been any period of time, but in that group of people, nearly 40% had at least a 2-month delay in getting their LARC removed. So this is actually kind of a striking finding, I think, because these are people who either they're having a side effect like bleeding that is bothering them, or they want to be pregnant, or they want it removed for whatever reason, but they're encountering all these barriers. And we do have data that shows that sometimes we as providers can be part of that barrier. So people were asked to delve a little bit more deeply into why they got their LARC removed later than they wanted. And the most common reasons were they couldn't get an appointment sooner, which reflects other barriers to timely care. But 23% said that their provider encouraged them to keep it. Another 12% said they had to attend multiple visits before they could get a removal. 11% had difficulty finding a provider willing to remove. So these kind of all speak to what we're talking about today about the patient experience. And in qualitative interviews, there's multiple qualitative studies where people were interviewed about these experiences. And I think one of the things that's really important to recognize is that sometimes questions or suggestions that we interpret as like positive coaching or encouragement, like hang in there, you can do it, you can make it to 6 months. When a patient doesn't want to continue, if they're having trouble really telling you that, or if you're kind of really pushing for that continuation, people can experience even subtle things like that as real coercion. And so I think that's part of why we want to be really clear in a situation like this of saying to Joselle, like, if you want this implant out, I'm going to take it out, or I'm going to send, I'm going to tell you where to go to get it taken out. And if she wants to keep it in, we'll offer ibuprofen, we'll offer birth control pills, we'll offer doxycycline, we'll offer, any evidence-based regimen that would help her continue the LARC and be satisfied with it. But if she wants it out, that our kind of, encouragement might actually be detrimental as opposed to helpful in this situation. So here's another case, another situation that comes up frequently in clinical practice. And this person is named Jade. Jade is a 19-year-old who uses the they, them, theirs pronouns. Jade's interested in a highly effective contraceptive method, and they read online that Mirena makes people gain weight. So I think scarcely a day goes by where we're not having conversations about weight. And I think that this is an area where it can be really helpful to have done a little bit of self-reflection about weight and weight bias and attitudes, kind of just in your own life, on your own time, thinking about it, because I think, many of us grow up in cultures that are, saturated with, ideas of like thinness as better, or frankly, if in your own life you felt the opposite, whatever our own biases are, I think this is an area where it's important to have an understanding of that so that we're able to take a pause and see what the patient's values are and not kind of impose our own sense that weight gain would be good or bad or not good or bad, right? Or indifferent. So, and how about the read online, right? So that comes up a lot too. Like someone may have heard from a friend or read online. So often we're, working with patients who have some information or misinformation coming into the visit. So how do we deal with this? How are we going to approach this conversation? So one suggestion I want to offer, so this is just I did a little Googling myself of Mirena and weight gain. And, as we know, right, there's often a selection bias in who's posting online. People aren't going online to talk about not having weight gain. People are going online to talk about having weight gain. The absence of a side effect is not as interesting as a side effect. And so, there's a lot of information out there, and, a lot of it is pretty selective. So I think that one thing that can be helpful in a situation like this, before coming in with like, here's the information, here's the real information, is to honor the fact that like, someone's doing a positive thing, right? Which is trying to seek out information. And I think that we want to recognize that and be open to that and even encouraging of that. And I'm glad that you're looking for information. I'm very happy to help fill in some of the gaps, and to even ask people to really elicit, like, so tell me about what you read. And that can also help set a baseline. And actually, I think that can be a really helpful technique with any patient education, so that, if someone's coming in, say, wanting to start, from our previous example, wanting to start Depo, just even so that you're not, reiterating information they already have, or so that you're going to successfully be able to deal with misinformation that they may have, asking them right up front, like, tell me everything you already know, and then I'll help fill in the gaps. And, one thing that makes birth control really different from other medical topics, right, is that nearly everyone who can get pregnant uses it at some point. So people have often coming in having heard a lot of stories and information. There was a recent study that was conducted in Chicago, and about 27% of patients had already come in having heard negative stories about LARCs in particular. And we know that patients do take this seriously, but we also know from studies that patients, including young people, take clinicians' input really seriously too. So we have a role to play here. So here are some examples of some questions that you would ask Jade in order to counsel them well. So you want to know what their weight goals are, right? Like, you want to know, are they trying to lose weight, gain weight, maintain? That's relevant information. What would it be like for them if they gained weight? And you might even ask here, it's not on the slide, but like, if they are concerned about weight, what are they doing now to either maintain their weight, to lose weight, whatever their goal is? Are they exercising? What are their eating patterns, things like that? What are their pregnancy goals? So, we already did have on the last slide that Jade wanted a highly effective method, but that's of course always a really important baseline question in contraceptive counseling. And then sometimes we make the assumption that if someone's using birth control, that it's really important to them to prevent pregnancy. That's not always the case, and it can be really helpful to ask that in an open-ended way. What side effects would be okay with them and what would not be okay with them? And then, as we talked about, what information did they find online? So here's some of the answers to that. So Jade says, I gained a lot of weight when I used the shot, and it took me a long time to use it. So that's not an uncommon experience. I don't want that to happen again. If I get the Mirena, will I gain weight? So, I wish now in hindsight I had thrown a polling question in here, but I will tell you that in past times of presenting this information in rooms, I have people like kind of commit to, would you answer yes or no? If you had to choose yes or no to this question, if I get the Mirena, will I gain weight? And people, like, you can see people don't want to raise their hand. Like, I wouldn't want to either. Like, it's a nuanced and hard question. And you really don't know, right? Is this particular individual going to gain weight? But this is what they want to know. So, and part of why this is a hard question to answer is that the data is challenging here. So what does the science show about weight gain on Mirena and other progestin-only contraceptives? So there is little evidence of weight gain on the levonorgestrel IUD, on Mirena or other progestin-only IUDs or progestin IUDs. So in most studies, users of progestin-only contraceptives like Mirena do not gain any more weight than users of non-hormonal contraceptives like the Paragard. So in a meta-analysis of 22 studies, there was mean weight gain at 6 and 12 months that was less than 2 kilograms, so less than a little over 4 pounds. But here's the thing that's interesting about this data. It's not that people weren't gaining weight on Mirena, it's that people were also gaining weight on Paragard. So this is a rough fact of our lives, right? If we're trying not to gain weight, as in Jade's case, is that lots of people gain weight on contraceptives, but they also gain weight not on contraceptives, or they also gain weight on non-hormonal contraceptives. And from a medical perspective, right, the magnitude of that weight gain doesn't necessarily seem a lot or alarming, but it could be alarming to an individual. So I think this is a critical point. It can be hard to explain. And one more thing just to know is that overall, the quality of these studies is not high. And I think part of that goes to what's valued by people versus what's valued by the science. So, researchers often value like different things than patients do. And I think that's an important thing to recognize. So I think the most honest answer to this is that some people do gain weight on Mirena, and also some people gain weight not using anything at all. And so in that case, I think you could honestly convey to Jade that she could have, less expectation of weight gain on Mirena than she had on Depo. So let's look just in terms of comparison for other methods. So there's no causal association for weight gain for combined hormonal contraception. So the pill looks really similar to the Mirena studies. People do gain weight, people complain of weight gain, and people on placebo also have that same experience. However, Implant, there's some mixed results in the studies, based on different study design. And then there's more consistent evidence of weight gain for Depo. And I'm sure that, many of you do counsel patients who are initiating Depo, that there can be an association between use of the Depo shot and weight gain. And there have been a number of studies that have really tried to look at the mechanism for this. And there's evidence that it's not just increased appetite, like it's not just factors that are sort of a little bit more behavioral or may seem more within our control. But there's actually a change in the deposition of fat mass and in lean mass. So again, just thinking about these goals of encounters, so to empathize, to normalize, offer options and range, and making a plan that works for people. Here are some sample statements that we can use in accordance with those. So empathize. I hear that you're concerned about weight gain. So even just, that kind of reflecting back to someone that you're listening to them and you hear what they're saying can be a way of expressing empathy. Yeah, weight gain can be bothersome for people. Let's talk more about this and kind of just open the floor a little bit more. Normalize. I hear from a lot of patients about weight concerns. I'm glad you brought this up. Offer information. So here's how we tried to distill those complicated slides. A number of studies have looked at this question, and in most studies, having a Mirena doesn't make people more likely to gain weight than people who are using an IUD without hormones. The weight gain is common overall. What questions do you have? And then make a plan. You presented all that. What are your thoughts? Or you can ask, weight is very personal, and I'm here to help work with you to find strategies so that you can be at your desired weight. Is that something you want to talk more about today? So kind of leaving things open. And I think, as we talked about before, one of the most important tactics of patient-centered counseling is not trying to drive to an outcome, but to leave the door open. And even when someone has made a decision, say, Joselle in our previous example, she kept the implant in. Let's say that you told her that about half of the time it gets better. And she's like, all right, I'm going to wait it out. Making that plan that leaves that door open of like, I really want to hear how you're doing. Pop by in a few weeks and let me know how the bleeding's going. I think can really help to establish for the patient that like you're there to be a trusted source of information, and that you're really open to their concerns. So Jade ends up deciding not sure the Mirena is right for them. And one thing to recognize here is that I think sometimes in a case like this, we could end up feeling like, oh, did we not express correctly the risk of weight gain if they're leaving without the Mirena? Sometimes there's an underlying concern about something that maybe someone's not bringing up or isn't talking about, and they can point to something like weight gain that's like a little more familiar. And it may be that you dispel that and they're just still kind of not that into it. And I think, recognizing that, and that's something that's well reflected in qualitative studies, is an important thing to know. Jade plans to use condoms. So what's your job? Making a plan that works for them, talking all about, can you show me how to use a condom? Can we talk through how are you going to talk with your partners about condoms? Really helping people optimize the use of their method is such an important part of our work. There's that big range, as you all know, between typical use and typical use and perfect use effectiveness. We can do a lot of work to bridge that gap for those methods like condoms where there is a gap. And then planning to have some emergency contraception on hand, which can definitely be a technique to improve the effectiveness of condoms and other barriers. So again, just back to that shared decision-making, we're trying to stay in that little shaded region. And in summary, patient-centered counseling can improve patient experience and clinical outcomes. Really important point to emphasize that people can have their IUD or implant removed whenever they want for whatever reason. And that sometimes even frankly just asking like, why do you want it out can feel not great to people. And invest in the experience rather than the method or the outcome. So it's time for questions. And you can feel free to throw them in the chat, in the Q&A box, wherever is most convenient for you all. I'm really happy to take your questions and to have some discussion. Great. So Kristen asks, can you talk about some ways to help with the irregular bleeding? So irregular bleeding on the implant, the studies are a little bit different between the different progestin-only contraceptives. For the implant in particular, just to back up a little bit to the mechanism, right? So when someone has only progestin on board, that can be kind of destabilizing to the lining. So that's the cause. And so then what we do is to match that. I'm going to bring up a slide. I hope I successfully brought up this slide. I'll be so happy if it worked. So the ways that we can kind of counter that are with any intervention that can help to stabilize that lining. So there's a variety, and the choice of the regimen can be based on, other conditions, interactions, cost, coverage, etc. But NSAIDs are an option, oral contraceptives if the person doesn't have contraindications to estrogen, or doxycycline. So this is actually a little snip. This is probably the most high value slide in this whole deck. But this goes through, this is a really nice review article by Rachel Ziegler about unscheduled vaginal bleeding with progestin-only contraceptives. But the NSAIDs, ibuprofen, of course, is the one we most frequently use. Oral contraceptives, usually just one pack is sufficient to stabilize the lining. And then the person can go back to just using their implant. That's perfectly safe as long as they don't have other contraindications, or doxycycline. These other, mifepristone and others are options, but less easily available and more costly. So thank you for that question. I know that comes up a lot. Other questions? Great. So I'm going to read this aloud. Number one reason trans patients aren't coming back for care: providers misgendering and discussing bodies and gender terms. I appreciate this webinar, and it's been hard to stay present in it as a trans person who supports trans patients. So I appreciate that, that comment and that question. And I think I noticed myself actually once in Jade's case misgendering them and caught myself, but that is, that's on me. And that is a reality of what people go through in care. And you're absolutely right. And it's a major issue for continuing care. I think that, recognizing our own slip-ups and limitations and seeking out ongoing knowledge. There's really great material and webinars available. At UCSF, there's a Center for Excellence in Care for Transgender Folks, and there's the WPATH guidelines and other information on that website, but I know that's been a very helpful resource for me. So I appreciate that. And I think that one thing that I think many of us are trying to do more in the sexual and reproductive health field is recognize that, people use contraception, not just women, people with vaginas, people with penises, all kinds of people can benefit from patient-centered contraceptive counseling. And part of that does come from, from being really willing to be open-ended and figure out what people's goals are. So thank you for that. Another comment that just came in, one of my providers will recommend a NuvaRing for people who have irregular bleeding. She said it helps people who can't remember a ring, and the body is able to absorb the estrogen as needed. So I think that's there's every reason to think that that is clinically sound. I think it's a totally fine thing to do. There aren't any studies that attest to its efficacy, but I think there's no reason to think, right, that it wouldn't have the same therapeutic benefits that oral contraceptives would. And then, how does the doxycycline improve bleeding? This is such a good question. And the answer is that we actually don't really have a fully fleshed out understanding of it. It's not, what we do know is that it's not from its antibiotic function. So it's not that there's an underlying infection. The proposed mechanism is that there's an inhibition of, it's a protein. It's MMP is the abbreviation, but I'm not going to necessarily get it right. And it inhibits, the doxycycline inhibits the role of that MMP protein in tissue remodeling. And so it can help to inhibit the unscheduled bleeding or the bothersome bleeding through the inhibition of that tissue remodeling. So a little complicated, maybe hard to explain to patients, but I think you can definitely say that, even though this is an antibiotic, I'm not giving it to you because I'm concerned you have an infection. We just know from studies that doxycycline can help to alleviate the irregular bleeding that you're experiencing. So I think I probably have to move things over to the concluding slides, but we can definitely do more questions if there's time. And so I'm going to unshare my slides. I really appreciate these questions. It was really great to discuss this with you all.
Thank you, Lisa. One moment here. All right. If you do still have any additional questions, now is the time to enter those questions into the chat box in your Zoom control window. While you're entering your questions, we do have a few announcements we would like to share with you. Please join us and become a member. The School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based healthcare. Our members extend and support our work. Trainings like this webinar would not be possible without the support of our members. In addition, our members receive exclusive access to valuable programs, timely publications, and networking opportunities. Please take a moment after this presentation to visit www.sbh4, that is the number 4, all.org/membership for more information and to join. Also, please visit our website to learn more about our upcoming 2020 National School-Based Healthcare Convention that will take place June 23rd through June 25th at the Sheraton Denver downtown in Denver, Colorado. Join the School-Based Health Alliance, the Colorado Association for School-Based Healthcare, and your peers from around the nation for 3 days of engaging workshops, networking, and fun. The theme for the convening is school-based healthcare, elevating a school climate of health and safety. As the premier national gathering for our field, the convention is a fantastic opportunity to connect with hundreds of fellow school-based healthcare professionals and advocates from across the nation. We are also currently accepting abstracts. The abstract submission portal will close this Monday, November 4th. Now, I believe some other questions came in. So there was one question that came in. Do many patients who need emergency contraceptive choose an IUD? Lisa?
Yeah, so thank you. This is a really good question. And the answer is that not many do, but when it's really made an option, and there was actually a really amazing demonstration project of this done a couple years ago in some Planned Parenthood health centers, that when staff really know how to like make that flow happen and make that a real option for people, that more people choose it. You know, most people still will choose and are fine with and happy with an oral option, but that one of the more common reasons that people don't choose an IUD for emergency contraceptive is just that it's not made an option to them, and that we haven't figured out ways in our clinics to provide it effectively. Oh, I think there's something in the Q&A box. Amy, how effective is Doxy in long-term bleeding? I've heard this works better for Paragard than Mirena. Also, can it be used as a treatment for Nexplanon spotting? So it can be used for the progestin-only methods for Mirena and Nexplanon, but for the short term. So the duration for that is for the short term. It's not necessarily used as a long-term solution. I don't know offhand of any studies of using doxycycline for Paragard-related bleeding. And I'm not sure. I think because the mechanism is a little bit different, it might not be as effective. I think NSAIDs are probably still the top line go-to for the copper IUD.
Just allow a couple of more minutes for any more questions to roll in. While we are waiting for more questions, there is a poll that should be popping up on your screen. All right, and there's one more poll question. Again, please feel free to submit any questions in either the chat box or the Q&A tool.
What I see in the chat, Shannon's asking clinician references for common interventions. Are you looking for is this the interventions for the progestin-related bleeding? I'll offer that. Oh, awesome. Here is a link to the full text. It may be one of those annoying things that's behind a paywall, but let me see if I can pop that slide up so that you can at least see that one more time. Oh, I guess I can't. Oh, and one more slide, one more question in the Q&A. Is it okay for a patient to stay on oral contraceptives indefinitely when using Nexplanon to stop the bleeding? So this is a great question where, the data doesn't necessarily give us all the information we need. So in the studies, they're all studies of short-term use. That said, in clinical practice, I've absolutely seen people use oral contraceptives for longer periods of time. Not necessarily indefinitely, sometimes intermittently, because, as we know from the studies of the implant, it doesn't necessarily taper off in a linear fashion. It can kind of come and go, the bleeding. So I think that this is one of those areas where, you may have to use clinical judgment and talk with the patient about what's acceptable to them, but there's probably no reason for someone who would otherwise be safe for using oral contraceptives. We don't have any reason to suggest that it would be a problem to use it along with the implant, but it's a little bit of a data-free zone.
Alrighty. If there aren't any more questions, I would like to conclude the webinar. Again, thank you, Lisa, and thank you to our attendees for joining us today. If you do have any additional questions, please feel free to send them to the email displayed on your screen right now. That is info@sbh4, the number 4, all.org, and I will be sure to send out the references that were sent into the chat box. Again, thank you for joining us today. Have a wonderful day.